Hi guys, I'm Bailey. Most of you know me. I'm going to be presenting afternoon report today. Next slide. So chief complaint is shortness of breath. So we have a 64-year-old African-American male. He has a past medical history of diabetes, type 2, hypertension, and he presented to the ED with mild chest pain and worsening shortness of breath for the past 5 days. Originally, he reported he was feeling short of breath on exertion, which improved at rest, and his symptoms came on gradually over the past month, but were worse over the past 5 days. He has been experiencing self-reported low-grade fevers, cough productive of sputum, bilateral lower extremity edema that improved before coming to the ED, and he reported having thick urine during this time. So more about the patient. So his past medical history, upon further interview, he had renal cell carcinoma. He didn't really know when, but it was in the early 2000s. Hypertension, diabetes, like I said before, he wasn't taking any medications daily, but he was prescribed metformin and lisinopril that he just never picked up and didn't want to take. He has no known drug allergies, and he's vaccinated with Pfizer 1 dose in May. So more about the patient, his travel history. So patient travels back and forth from North Carolina to New York City on a monthly basis. He works as a medical malpractice lawyer in New York City, but lives in North Carolina with his family. Family history was positive for his mother having diabetes and hypertension. And as for social history, he drinks alcohol socially, usually beer, sometimes dark liquors. And he was a former smoker, less than half a pack per day in the 1980s, no drug use. So review of symptoms. So he had low-grade fevers. He had some weight loss. As for respiratory, cough and shortness of breath. CBS, he had chest pain and palpitations in the ED. GI and GU, he had thick urine. Neuro, he had some weakness and fatigue that he reported, and musculoskeletal, he had bilateral lower extremity swelling, no rashes.
All right, so before we go to the examination, what else would you like to ask?
Any evaluation of coronary anatomy previously that we know of?
No, we didn't have anything on file for him.
All right, so you want to know more about his cardiac history. What else about his symptoms, his past medical history, anything else important in this case?
Can you unpack a little bit more what thick urine means? Like, did he describe like color, foamy urine, blood, things like that?
Yeah, unfortunately, in the ED, he couldn't really describe it. And the urine sample that he gave was just normal urine. It was yellow and not foamy. It didn't look thick.
Yeah, thick urines, and it's a first for me as well. I've never heard that from a patient. But you know, you learn new things every day. What else? Also in the chat, Rafa asks, can you clarify that? What do you mean by the lower extremity edema?
So he had, I guess just to elaborate, he said that he was having swelling in his lower legs. That was new for him. He had never experienced that before.
Okay. And then
orthopnea, no. Smoker, yes. Remote history in the 1980s. He was smoking a few cigarettes daily, but then stopped.
Then Carla is asking us to quantify how far can he usually walk, how far can he walk before being dyspneic over the past 5 days?
So usually he can walk more than a block without becoming short of breath, but recently he was not able to walk more than a block. And he does use a walker to ambulate. Sorry, not a walker, a cane, totally lied.
Okay. Then Nadeem asks if there's any history of hemoptysis.
No hemoptysis.
Okay. And then Darren asks any sexual history or history of STDs. I guess that's because of the thick urine.
That's a good question. I did not ask him that question.
Okay. Arpan asks weight loss over what time frame? Okay, so how, like, over what time frame did he lose weight?
He said all of his symptoms happened within the past month before presenting to the ED.
Okay, so fairly rapid weight loss. Then John asked recent travel, surgery, clotting disorder. So by travel, I think we know that he travels back and forth from North Carolina. Does he fly or does he take?
He flies back and forth,
Okay.
but
Then
no travel outside of the United States.
all right. Any recent surgery?
No recent surgery.
Okay.
No clotting disorder that we know of.
Okay. And then Dr. Osorio asks, where in North Carolina does he live?
Oh, I'm not sure. Oh, actually, I do know Raleigh. Raleigh. I remember the wife saying that.
Okay.
Yeah, it's just more like North Carolina is a big state and there's
Yeah.
different parts, city, urban, rural, like basically what's his living? Is he living in a home? That kind of thing.
Yeah, he was living in a home. Definitely no barriers to any of his daily life stuff.
Then Nadeem asked about sick contacts.
No sick contacts.
Martin and Debbie are asking about history of incarceration.
No.
And then Tom's asking more about the leg swelling. Is it symmetric or asymmetric?
It was symmetric.
Okay. Tom, would you like to tell us why you're asking about how would that have a like a role to play in this?
Always got to keep the like DVT/PE on the differential, especially in a guy that's traveling.
Exactly. Yeah.
And then one more, did you say he had a history of renal cell carcinoma?
He did.
Okay.
It was something that we tried to look into, but he didn't really know much about it. The wife didn't know much about it, and we didn't have any records.
Okay, so like it's not like a new diagnosis or anything like, okay, because
No.
cancer obviously
Yeah.
would flag a little. Okay.
But great, that's very important, right? In a patient who's coming in with shortness of breath, this is really something which will help you in your workup and will make some diagnoses more likely and some, it guides your thought train. So it's very important to know. Okay, any other questions before we move on to the exam? So Arpan asks, how was the RCC treated? Chemo or radiation?
He was unclear.
Yeah.
The difference between chemo and radiation, and then not taking any medications. Yeah, he wasn't taking any medications, was linked with medical care, but like lost to follow up from his own personal beliefs.
All right. So let's move forward and talk about the vitals and exam.
Okay, so for vitals, can you just scroll up a little bit? Sorry. Okay, perfect. So for his vitals, blood pressure 131/109, pulse 103. His temperature was 98.6 originally, but then repeat when he was seen in the ED by the medicine team was 100.8, respiratory rate 21. His weight was 260. We don't have a previous weight, and he was saturating 97% on 2 liters nasal cannula. Apparently he desatted before we saw him, but it wasn't written in the ED vitals. For physical exam, significant things that we found. So he was tachycardic on auscultation, and it was irregular rhythm. There was no murmurs. For respiratory, he had left lung fields that were where he had diffusely decreased breath sounds and expiratory wheezing. For musculoskeletal, he had 2+ bilateral lower extremity edema from his feet to his knees, and his skin was cool, and he was clammy and diaphoretic.
All right. So does anything in the vitals or the physical exam make you think of a particular diagnosis or rule out something here, or something which is just notable? Okay, Nadeem says irregular rhythm. Is it AFib? Was it AFib?
Yeah.
Okay. Cool, clammy skin. So for legs. Tom, can you let us know what you're thinking?
I'm just thinking more like this could be like a little bit of a heart failure picture, or he does have renal disease. So you could be thinking like he's leaking protein or something. Like he has possible renal cell carcinoma, I should say, but yeah.
Yeah.
Leaking.
Anything else in this exam?
Yeah, he has decreased breath sounds bilaterally. So, we do want to be concerned for like some kind of lung involvement, whether it's, lung collapse or whether he has effusions or whatever. But yeah, the lungs don't sound normal.
So an abnormal lung exam, so that makes you think about some kind of lung involvement. But let's start with the vitals. So firstly, yeah, he is frankly hypoxic, right? He desaturated, so he does have hypoxia. So short dyspnea can be caused by lots of reasons. Some reasons cause hypoxia, some don't. So you now, because you know that he's hypoxic, you'll think of causes which will cause hypoxia as well, right? So that's something which you find out. So next you see he has a temperature, right? That's also very important. This patient with, respiratory symptoms, potential low-grade temp. So that makes you, go down the thought train of that. Definitely have to rule out infectious processes. What else in the examination? He's tachycardic. Does that make something a little worrisome here? Does that make, patient with tachycardia, this history, something you want to talk about? Tom was alluding to it earlier. Sepsis, definitely. And yeah, PE, as Nadeem said. So patient with history of malignancy, patient with lower extremity swelling, tachycardia, that's something which is staring at you. And also this patient's obese. So obese patients also have a higher risk for venous thromboembolism. And then you see the respiratory rate 21. I don't know if it's the true rate. If it is patient hypoxic, that means this patient is slightly working. So the patient's sicker than they appear to be. All right, exam. All right, we know that the respiratory examination is abnormal. So we're thinking about something in the lung, some organic lung disease, and then lower extremity edema, possibly cool, clammy. So potential, decreased perfusion. Might have to think about cardiac disease. All right, let's move forward to problem representation. Who wants to take a shot? And then we'll work together and we'll break it down into 3 parts. So who's going to take a shot?
I can try.
Go ahead, Ivan. Who is the patient? So we're going to break it down into 3 parts. Who is our patient? Who are we talking about? Can you categorize him in a in a way that it's more scientific and it evokes a picture of a problem representation?
64-year-old male with a past history of type 2 diabetes, hypertension, and renal cell carcinoma, presenting with a 5-day history of chest pain, shortness of breath, productive cough, and lower extremity edema, with the noticeable exam of tachycardia and irregular rhythm, cold, clammy skin, diffuse lung sounds with expiratory wheezes, and saturating 97% on 2 liters nasal cannula.
Right. So that's very good. That's very extensive. Let's try to break it down into broader categories. So it's a 64-year-old male. So, middle-aged to elderly, depending on which attending is in the room. So what's his significant comorbidities, right? He has a known history of a previous malignancy. So he is a patient with a previous malignancy. That's very important to keep in mind in these patients. Who presents with, month or was it a month or was it more? So I would say subacute. I wouldn't call it chronic. Shortness of breath and chest pain. So that's your, that's the symptoms. Then significant on examination with lower extremity edema and an abnormal auscultation. And then on exam also seem to be febrile, tachycardic, and hypoxic. Right. So that's broad, and that evokes a picture, right? This is a middle-aged to elderly patient, cancer patient, seen to be hypoxic, tachycardic, and we know what's wrong with his exam. Everybody agree with that, or anything else you would want to add in the problem representation, or subtract? I mean, problem representation needs to be concise so that you're not making it overly broad. So you should know what to rule out as well and what not to be added in the problem representation. That's as important as skill. If not, we can go ahead. So this is, Lily, you want to go ahead with your problem representation?
Yeah. So 64-year-old middle-aged man with subacute onset chest pain and shortness of breath, accompanied by cough productive of sputum, low-grade fevers, bilateral lower extremity edema, and recent weight loss. He was found to be febrile to 108 in the ED.
That sounds good. So let me just share my screen here, and then we can talk about something I thought was more appropriate in this case. So let's talk about dyspnea in patients with a history of malignancy. All right. So this is an important subset of patients you'll be taking care of, especially at Mount Sinai West and at Sloan. And it's, we always talk about dyspnea. So let's take it to another level and then come up with ways to think about subsets of patients and not just patients in general. So dyspnea in a patient with a known malignancy. And for the sake of this discussion, we'll keep it broad. So it could be any malignancy. And it could be in the, I mean, this was remote, but it could be in the past year or so. So let's just think about the kinds of patients you'll be seeing. So what are the organs which can be affected leading to dyspnea? So first of all, obviously it's the lung. All right. So in the lungs, what broad categories of illnesses can cause dyspnea or presentation similar to what we saw in this patient? The first one is obviously we have to look at the parenchyma. So what are parenchymal causes of dyspnea in patients with cancer? Anybody want to just blurt out something? So I see a couple of things in the chat. So ILD. Okay, so ILD, is there any particular ILD which you'll see more often in patients with cancer? I think ILD is one which you'll see and think about in the general, radiation. So that's more important. So I wouldn't call it ILD, I will call it radiation-induced fibrosis. All right, let's think about common things first. This patient had a fever, patient had a cough, had productive sputum. What do you think of? Pneumonia, right? So pneumonias, common things first. Pneumonias are very common in these patients. Any specific considerations why these patients are more at high risk for pneumonias? Good, immunocompromised. Immune suppression. Any other thing you would want to keep in mind for these patients with pneumonias? These patients, cancer patients, are in and out of the hospital all the time, right? They're going to infusion centers, in and out of the hospital. So you have to think about drug-resistant bugs in these patients. It's extremely important. One more thing. In a patient with a lung cancer, is there any specific type of pneumonia you would suspect? You have your garden variety pneumonias, and then in patients where you have, exactly, Tyler said, post-obstructive pneumonias. In patients with drainage issues, the airway secretions are not being cleared, there can be a post-obstructive pneumonia, and those patients tend to have, anaerobic organisms causing these pneumonias and are higher risk for abscesses. So that's an important subset of pneumonias to be considered. All right, so we talked about pneumonias, we talked about radiation. While we're talking about radiation, is there anything else related to therapy which can cause parenchymal lung problems? What other therapies do patients get? Okay, pneumonitis. What causes pneumonitis?
Rituximab.
Good. Immunotherapy. Let's keep it broad. Immunotherapy related pneumonitis. Pembro is good. Nadeem says aspiration. Yeah, I'll add it to the guidance of pneumonias. Sometimes these patients are debilitated, deconditioned, higher risk for aspiration. So we talked about radiation, we talked about immunotherapy. Any other traditional therapy which can lead to lung disease in cancer patients? Chemo, great. Nadeem, which chemo agents? Bleomycin. Excellent. This is a classic board question. Not board, but more of a USMLE question. What else? There was another one. Starts with a B as well. 2 chemo agents which cause lung fibrosis. Bleomycin and Busop. All right. So we talked about pneumonias. We talked about therapy. Anything else in the parenchyma which can lead to hypoxia or lung symptoms, dyspnea? Any malignancy. So you can think about, it can be a primary lung malignancy as well, right? So it can have disease burden. When you have tumors, which is filling up the alveoli, and that's causing symptoms in dyspnea and hypoxia. So this can be a primary lung malignancy. More commonly, it's usually METs, right? meds can lead to, and disease burden from meds can lead to lung symptoms. And then there's, a certain smaller subset of patients with lymphangitic spread, which can also lead to lung symptoms. All right, so we talked about the parenchyma. So now lung part 2. What's outside the parenchyma? I think somebody mentioned earlier. Yeah, pleural disease. And more commonly, effusions. These patients can have pneumos as well, but no particular malignancy. At least in my mind, I haven't heard of any malignancy causing higher rates of pneumothorax. Maybe because they have effusions, they get tapped, that can lead to higher rates of iatrogenic pneumothorax. But okay. All right, so that is lung. Anything else in the lung anybody can think of? Actually, let's just talk about vasculature because it's close to the lung. Any vascular causes of respiratory symptoms in cancer patients? Great, PE. Anything else? Certain lung cancer patients, you see this as a complication. Pulmonary hypertension, that's probably related to PE. It's like pulmonary thromboembolic disease leading to CTEPH, which is chronic thromboembolic pulmonary hypertension. But I'm thinking of like an entirely different category of vascular causes of dyspnea. So in patients with lung cancer, you can have SVC syndrome. So when you have obstruction of the SVC, that's going to lead to engorgement of all the veins, and that also leads to dyspnea. I think that's it for vascular. So that is what we'll talk about for the lungs. Let's talk about the heart now. How can cancers or having a malignancy affect the heart, which leads to dyspnea? So we'll talk about it in categories as well. What's the outer covering? Pericardium, right? So what can happen with the pericardium in cancer patients, which can lead to respiratory symptoms? Pericarditis. Okay, pericarditis. All right. What else? Pericardial effusions, right? These are more common. Malignant pericardial effusions are, it's something which you will see commonly in the CCU. Patients with cancer comes in, has a huge pericardial effusion, possible tamponade, comes in, gets a tap, gets a drain, the sample is sent for cytology, has a cancer, and then, that's how you work these patients up. What else? Anything else for the pericardium which you've seen in patients with cancer, especially in like survivorship patients who had remote cancers, patient who had a Hodgkin lymphoma in their 20s, come in the 40s. What commonly causes dyspnea in these patients? They receive radiation to the chest. So they can have constrictive pericarditis, right? So constrictive pericarditis is another entity you should think about in patients with a history of remote cancer who receive radiation to the chest. So that's the pericardium. Let's talk about the myocardium. What can cancer patients have? Myocarditis, good. Any inflammation, right? Immunotherapy can lead to any inflammation in the body. So immunotherapy associated myocarditis. Anything else affecting the myocardium? What chemo agents can lead to toxicity? Yeah, these dilated cardiomyopathy. I see doxorubicin. Any other agent which we know can cause cardiotoxicity, breast cancer patients? Good, trastuzumab. In HER2 positive? patients, you can have cardiotoxicity from trastuzumab. And then, these patients can have garden variety CHF. Some of these patients are high risk for cardiovascular disease, ischemic cardiomyopathy, and so forth and so forth. And then anything you can think about in the endocardium? Anything these patients are at higher risk for? Cancer patients frequently have lines, indwelling PIC lines. They're going to get chemo, they're going to be in and out of the hospital, vascular lines, so they can be at high risk for endocarditis, which is, if you're thinking about infective, but there's also a subset of non-infective endocarditis or rantic, which is seen in patients with hypocoagulability, right? So if a patient with cancer, pancreatic cancer, is associated with hypocoagulability, you can have non-infective endocarditis as well. All right, so we talked about the lungs, vasculature, and heart. Let's talk about other miscellaneous things. Anything else which can cause dyspnea in patients with cancer? Great. I really like that answer, Tyler. Ascites. Why would ascites lead to dyspnea?
Just like mechanically, if you have too much ascites, then you can't expand your lungs.
Excellent. Yeah, so it's going to decrease your lung capacity because it's going to press up on the diaphragm. So ascites can press the diaphragm. Anything else? These patients are frequently anemic, right? Anemia can lead to dyspnea. Then, yeah, good point from Tom. Capillary leak and low albumin states. So chronic malnutrition, hypoalbuminemia can lead to capillary leak. Nephrotic syndrome is a common one seen in some, not common, but it's a syndrome seen in some cancer patients. So that can lead to third spacing, pleural effusions, and that can present as dyspnea. We talked about anemia. I think one more is neuromuscular. So if you have a patient with a small cell carcinoma or a lung cancer, these patients can sometimes have paraneoplastic syndromes like Lambert-Eaton. So these can cause neuromuscular causes of weakness. And then, these patients are generally weak. So they will feel weaker than, they will have deconditioning weakness, and that can also lead to subjective dyspnea. All right, so I think we have a good framework. We can go ahead and talk more about our patient here. All right, Billy, you want to go ahead and talk about, or want to ask what workup you want?
Yeah. So what would you guys order if you had this patient in the ED?
I think we do need to be concerned for like the dangerous to life-threatening things. So on top of imaging, like a chest X-ray, a CT, I wouldn't be surprised if they did a CT angio.
Great. So let's just see, the basic workup's going to happen anyway. So this is what we saw.
So for labs, we got a CBC with differential, and we got coags. Nothing really on the CBC. Coags really can interpret right now at this point. But if we go to the next page, what really stood out to us in his labs is that he had pretty significant respiratory acidosis. His BMP was a little bit elevated at 235. He had positive tropes. He had an AKI. His normal kidney function was in the ones, like 1.3. We got an EKG on him as well because of that irregular rhythm, which is showing AFib, and it was RVR. And we did get a chest X-ray.
Does it seem normal or abnormal? Something seems off, right? Yeah.
So the chest X-ray was just showing basically complete opacification of the left lung with an and you see like a rightward mediastinal shift.
All right. So what do you guys think now? What can cause such massive ossification or unilateral ossification, white out?
Malignant.
Yeah, go ahead. So people saying pleural effusion, mucus plug. I agree with the pleural effusion. Mucus plug. So if you had whiteout from a mucus plug, what would you think would happen with the mediastinum and the trachea? It would go to the same side as the thing, right? So that's why you think it's not a mucus plug. It's probably an effusion, which is pushing it away. And then, all right, so we can go ahead and talk about this.
Oh, I was just gonna bring up what you can see too is the diaphragm, like how you can see on the right side the diaphragm. So just kind of seeing what is it that you can see on one side versus not the other. So it's so very clearly the diaphragm you can see on the right, which
Yeah.
I'm just kind of thinking about like the differential.
All right. CT.
Like Nadeem said, we also got a CT chest, and in the, I guess the right-sided image, I had a video, but since I can't share my screen, it doesn't pop up with the PDF. But this is just what the CT chest showed, and it just corroborated the chest X-ray. So massive left pleural effusion, and it was occupying the entire left hemithorax. And also that you can't see in this image, there were some sclerotic bone lesions as well as abdominal lymphadenopathy. So just to go over his hospital course. So when we did find the left-sided pleural effusion that was occupying the whole entire space, we called Palm. Palm did a thoracentesis. They drained 2.5 liters, but they didn't place a chest tube. Within the next 36 hours, the fluid reaccumulated and another 1.5 liters was drained. We sent the fluid for cytology analysis. And in the meantime, we also got a PSA, which was 5,000, CEA 34.8, and CA 19.9 was negative. He was Hemonc was consulted, and he was started on Degarlex 240 as a loading dose, and then Casodex for 50 milligrams daily. And cytology came back showing urothelial carcinoma, and the retroperitoneal mass showed metastatic prostate carcinoma. So this is going to start my discussion on pleural effusions, which I think is a pretty simple topic, but I feel like we don't really dive deep into it when we're in the hospital setting. So just as for symptoms that you would see, your patients are probably going to have dyspnea. They're going to, have some sort of pleuritic chest pain if it's large enough. Sometimes they present with cough, fever, if it's like infection, or left-sided heart failure symptoms, because some of our heart failure patients will present with some small pleural effusions or, sometimes larger. As for physical exam, you'll hear, or lack thereof, decreased breath sounds or absent breath sounds. You'll hear a pleural friction rub, and that whole side where the pleural effusion was, in his case, there's like dullness to percussion over the whole left side, but usually it's just over the area where the fluid is. So basically just a brief overview. Definition of pleural effusion: it's just a fluid collection between the parietal and visceral pleura. And it's broken down into two types. So transidative, you have fluid that permeates through the pleural cavity of intact pulmonary vessels. And then exudative is when the fluid escapes into the pleural cavity through lesions in blood and lymph vessels, which is usually secondary to inflammation and or tumors. So the pleural lining is a semi-permeable membrane, and it acts as a filter. I guess you could go to that slide, sorry. And so basically, just to go more in depth of what I stated before, in a transidative effusion, if the lining is intact, it'll filter large proteins, so the fluid will be very dilute. And if the membrane is damaged by inflammation, the capillary permeability increases, and fluid entering that space will contain large protein and inflammatory markers, and that's exudative. And in order to decipher if it's transidative and exudative, we all know that we need to have Palm do a thoracentesis, and so that we can do some fluid studies. And so in order to get that, you would use the Light's criteria. And if you want to go to the next slide, sorry. So here I have the Light's criteria and also the modified Light's criteria. We all know this table very well. The pleural serum protein ratio, if it's less than 0.5 or greater than 0.5, it'll just decipher between transidative and exudative. And then you can also use the LDH or the pleural fluid LDH. And you only need one of them to categorize if it's transidative versus exudative. So being that you only need to meet one of the criteria, this test that we use is considered very sensitive and not specific. And then just something to note that patients who are on diuretics, specifically in heart failure, it can falsely elevate the protein levels in into an exudative picture. But in order to really further categorize if that's falsely elevated or actually true, you can just see the serum pleural fluid albumin ratio. If it's greater than 1.2 or the protein ratio is greater than 3.1, then you know it's actually transidative, and that the diuretics were kind of giving you a false picture. If you want to go back to the original.
Just want to add that this is a very important board question, diuretics in patients with effusions. You will have a very common question in the boards where the patient will be on diuretics and will have an exudative picture, but if you calculate the ratios, it's actually transudative. So it's important to keep this in mind, and it's very frequently tested.
Yeah, the picture of the, yeah, thank you. So just to dive deeper into transidative effusion. So usually you'll have increased hydrostatic pressure and decreased oncotic pressure. And these types of effusions are usually due to heart problems, kidney problems, and like liver disease. So right here we see on the left side, most common is CHF, liver disease, ESRD, nephrotic syndrome, sometimes PE. And these are like our bread and butter cases that we see on the floors all the time. And then for our exudative effusions, we can break it down further into two different categories, which is our primary and our secondary. Primary is basically primary lung diseases that are increasing capillary permeability. And then the secondary etiologies, if we see a right-sided exudative pleural effusion, we want to think GU syndrome, so Meg syndrome, endometriosis. And if we see a left-sided exudative pleural effusion, we want to think GI syndrome, so pancreatitis, esophageal rupture. It's also really important to know that transidative effusions, you don't necessarily need to send the whole workup for, but exudative effusions, if you do calculate Light's criteria and it's met, you really want to get cell counts and differential. You want to send glucose, ADA. I didn't add it in here, but ANA is usually helpful sometimes for autoimmune. And if you find that it's like an empyema, you want to do bacterial cultures, pH, but that'll all depend on how the patient presents. So next, I want to talk about management of malignant pleural effusions, because I think that this is something that's important. And so it's a huge topic that I don't think that we need to know everything about, but the important points are how you treat it would be a therapeutic thoracentesis. And then if the fluid reaccumulates, which usually it does because there's a high percentage of reaccumulation, you would want to ask Palm if they want to do a pleurodesis versus an IPC, which is an indwelling pleural catheter. There was a study done, I think it was like 2015 or 2018, that said one or the other is fine. There's no increased success with one or the other. It's really just what that institution feels comfortable with. And then the next treatment would be really just treating the underlying malignancy. So for our patient, we did the thoracentesis first, we sent the fluid. We had to go back in there, drain some more fluid because the fluid reaccumulated in 36 hours and was causing him some significant symptoms. And Palm eventually had to put in a IPC. for draining of that fluid to make sure that his symptoms were controlled. And so management of malignant pleural effusions is usually palliative, and it doesn't necessarily improve survival. And the treatment really just focuses on sustained symptom relief and improvement of quality of life. If you had a patient who came in obviously with a pleural effusion that wasn't as severe as our patient, and they weren't having symptoms, and it was kind of an incidental finding with a malignancy workup, you wouldn't treat it. You would kind of just let it be. So just to wrap up today's afternoon report, I have a case just to calculate Light's criteria. And you can use MD-Calc for this, but we have a 34-year-old woman with a history of heavy alcohol use. She presents to the emergency room complaining of increasing shortness of breath and right-sided chest pain. Her past medical history is remarkable for several prior episodes of pancreatitis, and it's likely secondary to her chronic alcohol use. This is her chest X-ray. So they basically perform a thoracentesis for symptom relief, and they send fluid studies. And then they had to repeat the thoracentesis, which is likely usual. And so the fluid studies reveal that her LDH is 894 and her serum LDH is 175. Her total protein of the pleural fluid is 3.6 and serum is 5.3. White blood cells are 4,000 and she has 90% eosinophils. Gram stain was negative. So do you guys think that this is a transudative effusion or an exudative effusion? You could write it in the chat if you want.
Everybody's on MD-Calc right now.
Okay, good. Yeah. So basically the LDH value is way above the upper limit of normal for her serum, and the pleural fluid LDH ratio is greater than 0.6, and therefore it would be an exudative effusion. Thank you.